Season 2 of Food for Therapy podcast. I'm your host, Therese Bolden. Welcome to the show that combines my training and specialties of psychotherapy and counselling, personal development and writing with my love and my passion of food and hosting and culture. And today's episode, you're not going to want to miss this. If you've had any problems with pain, we've got our resident doctor, Doctor Euahna Varigos, who's a trained specialist anaesthetist and adjunct practitioner. We will be chatting all about pain management and her specialized treatment of laser light acupuncture. Thank you for joining me today, Euahna.
My pleasure.
Thank you. And on the menu today, I have to say, it's my husband's 40th, so I decided to make him his favorite dish, and it's moussaka. And all the recipe will be on the website, so stay tuned for that. Come and join us, take a seat and relax while I chat to Euahna. How are you?
I'm very well. And moussaka, a Greek
Yes,
dish,
yes.
which is apt, seeing I have a Greek
I
heritage.
know. I hope you like it. I hope it lives up to it for you.
I'm sure it will. And thank you for having me. And I suppose out of all the pain, pain is a huge topic. And because of my anesthetic specialty and having practiced as an anaesthetist for many years now, and also done a lot of interventional anesthetic blocks for chronic pain.
Mm-hmm.
But more recently, I've been working a lot with surgeons in the acute perioperative period. Now, people say, what is perioperative? It's the time before surgery and then the immediate time after surgery, which is often in hospital, because as an anaesthetist, I am accredited at certain hospitals, and I can go in and visit the patient, consult, and I've also been able to instill an LED PBM treatment for them, and then post-op in my rooms. So it's like it circumnavigates the whole journey of surgery for the patient.
So let's go back a bit. So what you do is you treat the patient with your laser light acupuncture prior to their surgery.
Yeah, I consult first. First of all, it's the consultation.
Right.
Prior to surgery, and some patients who have had chronic pain for a long time are going into surgery absolutely, totally sensitized. Their brain and their system is heightened because they've had chronic pain, and we do know the brain changes with chronic pain.
Right.
So we know that they're sensitized, and then they go.
Means what? Which means that any medication is not going to work for them.
Well, medication, they're often on as much medication as they can be to help, but they're going to surgery to help the pain. I'll give an example of joint replacements.
Okay.
So they've had pain for a long time. We don't rush into doing a joint replacement. So generally speaking, people have had pain for several years. That's just got worse.
Mm-hmm.
They're on tablets, they've been on drugs, they might have another pain, back pain as well. So they've got, all I'm saying is people who come and have a pain, chronic pain, we call it a syndrome, which I don't like, but have had experienced pain for a long time, in my opinion, and we know that the brain alters, the function of the brain alters and becomes sensitized to incoming messages. So it becomes sensitized to pain.
Right. Okay.
So what I'm saying is, if they're already in pain, they're now going to have surgery, which surgery is a planned injury, isn't it? We forget that. We just think of it, it's fixing me up.
Oh, that's an interesting way of looking at it.
Yeah, but it is a planned injury. It's an assault. Actually.
Right.
Well, I don't want to say that because the surgeons are very good, but it's an assault on the body.
Yeah.
And so we know you're going to have an injury. And in my opinion, we are not doing enough pre-op to maximize and optimize patients' recovery. If you have an injury, that's fine. Someone has an accident, they injure themselves, we have to pick up the pieces.
Mm-hmm.
Yeah? It's swollen, whatever, but we have to pick up the pieces and we act accordingly.
Mm-hmm.
But if you have pain, I know that your brain is sensitized because of that.
Mm-hmm.
You have inflammation and swelling probably around the area that's going to be operated, but we now then go and injure it with the operation, but the operation is a necessity,
right?
But it's an injury,
mm-hmm.
and there's an added inflammation swelling on top of what's already there.
Right.
So my aim, and how I see PBM and how I've seen it countless times,
PBM is
photobiomodulation.
Right.
So it's the use of photons or light to treat and target areas of tissue and the nervous system. And so you can reduce swelling and inflammation prior to the surgery. So if the patient is going into surgery to have the operation, which is going to cause swelling, but if they're going in with less swelling and less inflammation, still needing the operation, I'm not saying that it's going to cure your the total knee replacement you require, but I'm just saying the tissue around is optimized, right?
Okay.
And then the nervous system. So there are two things. So when a patient comes to see me, my first thing is, as an anaesthetist, I assess the patient and consult from a neurological point of view, whether there's nerve pain. Anyway, there's lots of things that I think about, but what I'm saying is there's a consultation and then a plan. I then plan how I think I can help them.
Yeah.
And going forward, if they work with surgeons I work with or in hospitals that I work at, then I plan to see them as close to the operation as possible. And then depending on the operation, depending on the patient as well, I'll see them post-op in the hospital if I can. And I generally can. I will now have
Please
something
have
to eat.
some. I want to know if you like it.
Okay, now then you can.
Really interesting.
That's a little,
because I know for a fact that your treatment of laser light acupuncture definitely worked on my menopause symptoms. I was a skeptic initially. I did come to you, though, with an open mind, and an open mind in the sense that I focused on what you call adjunct treatments or add-on treatments. I really wanted to see if it would work and the efficacy of it. And, you know, with menopause, it took 3 or 4 sessions before I started to see a difference. And I did see a difference. So I do know that it works. But obviously I haven't been treated for pre or post-operative, touch wood, and I haven't had any injuries. So I know that there is a lot of people that are living in this world with tremendous pain, whether it be pain from surgery or pain from an injury, and it's debilitating for them. So how does your treatment, simply, Euahna, how does your treatment help, right? And how long is it before a patient can start to see that it's actually working?
For chronic pain, it's more difficult because the chronicity, and it's hard to measure.
Yeah.
I can talk about someone who is going to have a knee operation, knee surgery, or foot surgery.
Right.
Knee and foot and hip are what I do a lot, mainly, or a lot of. I tend to work with those surgeons. Patients who come with knowing that or having to have an operation on the knee and the foot or the hip will nearly always say it's a bit swollen, it's sore, and it's a bit inflamed, right? And before the operation, they usually have to go off their anti-inflammatories, which tends to sort of stir things, increase their symptoms a little bit, not always, but sometimes.
Yeah.
And so if we're looking at a patient who comes to me in the prior to surgery, and they've got a bit of swelling, they've got a bit of inflammation, I won't go into the way I treat it depending on what else is going on, but patients will see a change immediately. They'll see a change within the half hour of the treatment.
Oh, that's amazing. Because I know even with menopause, it took 3 or 4 sessions.
It's a different thing.
Oh, right.
This is now the lymphatics. So I'm actually...
Explain to whoever's listening.
The lymphatics?
Yeah, what that system is and what it does for our body.
So the lymphatics, in my opinion, is the forgotten system. You know, go back to Egyptian, ancient Greek, TCM, traditional Chinese medicine, Ayurvedic, which is the Indian. They all talk about the phlegm or the fluid in the body, not the heart, not the blood. They're talking about the extra fluid that is in our body, which we forget is always being, how can I say, the lymphatic system is like a system without a pump that pushes fluid from wherever it's accumulated up the body against gravity into the thoracic duct, which is a collection here, and goes into the heart.
Oh, wow.
So when you swell up when you go on a plane, your ankles swell.
Yes.
They go down, don't they?
Yes.
Where does the fluid go?
Oh, it's the lymphatic drainage that's working.
Yes.
Right.
Where and how does it go? If you think about it.
Yeah, absolutely.
Because if nothing was there to get rid of it, we just progressively get swollen, and you do see people who have a problem with their lymphatics.
Yeah.
Now, I don't know anything apart from light, photons, which is what I use, that helps the lymphatic system as effectively. There isn't a drug. If there was a drug that worked on the lymphatic system, everyone post-op would be on this drug to help with the swelling.
Yeah.
But there isn't a drug, and it's probably because it would be too many side effects. I don't know.
You're
I'm
so
not
clever.
I'm just looking at
but
things.
isn't it? But the way that you look at things, and that's one of the things that I love about your brain, Euahna, is that you're not just looking at an individual from a physical perspective.
No.
And this is what this podcast is about. It's about the integration.
That's right.
You know, it's the mind, it's the body, it's the lymphatics, it's the soul, it's the spirit, it's all of that.
That's right. And you're right. And I don't like the word holistic, that I am a holistic practitioner.
No,
but
we said adjunct.
Yeah, but holistic meaning global. I think about everything.
Yeah.
I think about, I have patients. Let's just talk about the lymphatics though first. Let's get over this one. So the lymphatics are very crucial and very important to the function of us as human beings.
Right.
We don't think about them. And
well, we take it for granted.
Well, is there a lymphologist?
No.
Is there a special?
No, I've never seen one.
No, and if I had my time again, I would become a lymphologist. Okay, we have hematologists, and they deal with cancers in the lymphatic, the blood cancers and everything. But there are a few lymphologists, but they are actually more research scientists.
I've never even heard.
No, they're not practitioners that you go and see.
Right.
Although the surgeon I was working, the rooms I was working with, he's a plastic surgeon, and his specialty is the lymphatic system. So he helps with people with lymphatic issues.
Right.
But where I'm saying, with respect to PBM for photobiomodulation for a perioperative period, I'm saying the swelling post-op is an issue, and it happens because you've been injured. And it's a natural thing that happens.
Through the surgery.
Well, yeah, surgery cuts into whatever's going on.
Yes.
Blood, there is a blood. There are tissues that are damaged, so that all secretes out. There's an inflammatory reaction, which is we need.
Right.
But what happens is if the lymphatic system is not optimized prior to this, which is what I'm doing, I optimize whatever your lymphatic system can do. I'm trying to get it as good as it can be prior to the surgery, so that then you don't swell up. You don't have as much retained swelling post-op. You always will get it.
Right.
But it will not cause as much pain, because one of the problems with swelling in knees and feet and hips is that you get more pain. Because there's swelling will give patient, and if you ask patients, when it's very swollen, it's much more painful. So that's one of the things that I aim to do. And as I said, patients will generally see a change. I'm trying to think, you can never say everyone.
No, everybody's
100%.
different. Everybody's different.
However, there will be a change in the majority of people that I treat, that I can see, but they can see.
Right.
And
so that's another thing. How do you measure that? Let me play devil's advocate, Euahna. I know that your treatment works because I've had your treatment. I know it took a few sessions for me. But what about those people that go, it's just placebo?
Well, my cynics, the cynics I get are my best advocates. Yeah. Especially if they've come for perioperative work.
Right.
Because they go, oh my God, I didn't think anything was going to work. I just, he said, Mr. So-and-so told me to come. I didn't really expect anything, especially not on the day, but it's changed. And And it doesn't last, well, depending on the chronicity, it doesn't last, but it'll wear off a little bit. But it's cumulative. So sometimes with some patients who have a chronic issue, they've had surgery and they've got a chronic issue post-op, then I have to see them weekly or every 10 days for 4 or 5 treatments to consolidate the change.
Right.
And that, as I said, they are my best advocates afterwards because nothing has worked before.
Yeah.
And
so what is it about your laser treatment? Because again, I say when I first came to you, I actually thought I was going to have some needles, the traditional laser acupuncture, but I was pleasantly surprised that it was non-invasive and it was a rod. And
I'll show you.
What is it
brought
about?
It with me today.
What is it about this magic wand?
It is a bit like that, and I had a surgeon that used to say, the magic wand is coming, and I go, no, please don't say that.
But
in the ward when he saw me. So I'm not sure whether we've spoken about this before, about how but we did talk about how I became interested in medical acupuncture.
You can talk about
that again.
Yeah, I think it's important.
It's important because I'm an anaesthetist.
Yeah, that's right.
So
you're trained with science.
Here I am working as an anaesthetist. I had 3 young children, and I decided I was not really happy in theatre anymore, and it was very difficult. My husband at the time was an anaesthetist, so he was leaving at 6:30. I was leaving at 7:30. It was a bit not ideal for my children. So I decided I wanted to get into something that was still as an anaesthetist, but not in theatre. And pain management was, especially when I did this in 95, was under the umbrella of the anaesthetic college, and it still is.
Oh, okay.
So the pain, but now that we have pain fellowships as well. But before that, it was basically nearly all pain physicians were anaesthetists.
Yeah.
And if not, they were in the anaesthetic college.
Okay.
There was a little pain fellowship that began. So that's how I started to get into something that was not traditionally giving anaesthetics.
Right.
But also it meant that I was doing a lot of interventional blocks. So as an anaesthetist, we're trained to do epidural, spinal blocks and everything. So we've always been the main people to do back blocks, RFD, radio frequency denervation. People might know that, local anaesthetic and cortisone blocks. So in the 90s and early 2000s, we were doing the majority. Now a lot of radiologists are starting to do a lot of the interventions as well. Okay. However, we were basically the ones because of our training.
Of course, yeah.
Because we're already trained to do blocks. So it was just an added thing to do the block for chronic pain, not for giving an anaesthetic.
Yeah.
And so when I started looking into pain, I went to the pain clinics back in 94, and I was disillusioned to find that there was very little interventions done, some, but the majority of things were writing scripts of what we used to call MS Contin, which is morphine.
Oh, yes.
And giving morphine to patients. They were just coming in and going.
That people are dying over in America.
Well, that's OxyContin, but it's the same idea. Yeah. And that's it.
And
OxyContin got a different name.
It's addictive.
It is addictive.
Dear.
So patients were being given MS Contin. And I remember saying, I don't want to do this. I actually think I probably lent to being an anaesthetist for a number of reasons. One, I was very good with my hands, so I could do all the intravenous's and do all that as a resident. But also, I really had a funny aversion to writing scripts.
Yeah.
I was always concerned about what this drug was going to be doing to the patient when they're gone. And I would spend hours explaining all the side effects as a young resident.
Right.
So I think what happened, it sort of meant that, I don't want to do that. I don't want to be a physician. I would do anesthesia because actually one of the reasons was my father said it was he was a doctor, and he said it's a good specialty. But also the charge sisters on the ward when I was a resident would say, Euahna, can you try to put that drip in so and so? The other resident can't get it.
Right.
And I used to get the drips in before we call the anaesthetic registrar.
Oh, wow.
So what do you think my little brain thought? Oh,
yeah,
I'll do anaesthetics.
Yeah.
So that's how I got into anaesthetics. But it meant then when I was giving drugs, I was looking after you, right? I was not giving you a drug to go off and take.
Right.
So there was this time where I was looking after you with very, how can I say, very powerful drugs we use.
Yeah.
But we are watching you and we look after you, and then you recover, and then you're off. So I can see that was my ethos. Yes,
well, it's ethics as well.
And so when I saw this in the pain clinics, I said, well, I can't do that. I cannot be sitting there writing scripts for morphine to people.
Right.
And I initially went back to anaesthetics for a while, and I said, oh, can't do that. And I was talking to my brother, who is professor of dermatology at Melbourne University and the Royal Melbourne, and very academic, and works at the Walter and Eliza and does all this research. And I said, George, I can't write scripts. I cannot do pain management, write scripts as a pain physician, but I have to do something. I can't go back into theatre anymore. I don't feel comfortable. I've even thought, and these were my words, I've even thought of doing fellowship in medical acupuncture.
Right.
And he said, good idea. And I'll never forget it. He can't remember this, but he said, good idea.
Yeah, the turning point for you.
And it was a sliding door for me.
Yeah.
Because then the next day, I was actually in hospital when he said this. Next day, I rang up, and the rest is history. Off I go, and I do the medical acupuncture fellowship. And the interesting thing is that it was this was in 95, and it was the Medical Acupuncture Society was started in 1973.
Oh, wow.
Here in Melbourne by the director of anaesthetics at Panch. So it was an anaesthetist who went to sabbatical to China, came back and said, we're starting an acupuncture clinic. And what happened, they were using needles, but in the 80s, because of HIV and Hep B, the other departments were going to close the acupuncture clinic down.
Right.
We said, we're going to close you down because you're using needles and you will spread
whatever.
Yeah. Let alone all the needles that are used in the rest of the hospital. Yeah. However, they knew that if anyone got AIDS or Hep B and had come to the clinic, they would be the scapegoat.
Oh, wow.
So they'd heard that you could use very low-level laser. So there's a long story to get onto this, but very low-level laser that could stimulate acupuncture points. So what they did in 6 months, they did their audit, changed totally to using laser, and found their results were similar, even with work care, which is a big thing. And they said, well, we're not using needles anymore, even though they were disposable.
Right.
So they survived. Otherwise, there would be not the medical acupuncturists in Melbourne or in Australia. It was the survival. And so when I did my course in 95, I was introduced to laser, not this one in particular, but the same concept of a light, not as strong as this. You don't need it as strong to do the treatment, but that's what would happen. It would go through where the acupuncture point is and treat the nerve, stimulate the nerve.
So what I'm hearing you say, because it's the perioperative work is your focus, and what I'm hearing you say is that in doing the perioperative work with the laser light acupuncture, you're reducing the time around healing after surgery and the swelling. Is that right?
Yes, I use laser acupuncture, but I also use laser therapy, which is laser, which I don't know, you've not, did you experience the LED?
Oh, I did have LED, yeah.
So the LED is not actually aiming at acupuncture points. However, I do both.
Yes.
And the acupuncture points, which you experienced, that calm you down
Yes,
are what
yes.
I do prior to surgery, because patients are
Ah.
anxious.
Right, so it's the nervous system.
So I treat the nervous system, and I treat the lymphatic system, and I
Yeah.
treat the operating site.
Oh, you treat the site as well.
Pre-op.
That's amazing.
So it's a very, it's a combination. It's not just one thing. And I've protocol now over the last 15 years probably.
So if someone's coming to you and they're going to have surgery on their back, let's say they, I don't know, their spine's out of alignment, or they've got a disc that's, you know, and they're having surgery on that. So you're saying that they could have one session and that they would feel the efficacy of this treatment immediately, or it would have to be after that they would feel it, after the surgery?
Backs are not as easy to see the change, but patients will feel the calmness. They will feel the anxiolytic effect.
Right.
For example, yesterday I treated a woman who was in hospital having a total hip replacement. And I treated her prior, and she actually commented to the surgeon. She said, as soon as she did these points, it was like I just went, as if someone had given me Valium.
I know. I had that when you first did. Yeah, I felt like I wanted to sleep.
That's right.
Yeah,
so you can imagine prior to surgery, or the night before surgery, how beneficial that is. Yeah. And one surgeon I used to work with, the patients used to be admitted the night before, which does not happen now, but this was in 2010. And he commented, he said, Euahna, whatever you are doing, the patients are coming to theatre like the good old days when we used to give everyone a really heavy pre-med to make them calm. We can't do that now because it's a respiratory depression and stuff like that. But anyway, they were coming down calm and easy to anaesthetize, for one thing.
Right.
Much easier to anaesthetize a patient who's calm. But the other thing, and
why is that? What happens?
Because we don't need as much of the drug.
Fascinating.
You know, you will respond more quickly. Rather, if you've got someone fighting, we have to give you more, and you know we still have to.
And general anaesthetic would take a lot longer to overcome.
And it just often in my, not that I've given anaesthetics for a while now, but I do remember the anxious patient is not easy.
Definitely.
Even for us in theatre and afterwards and post-op in recovery.
Yeah.
But the other thing, there are studies to show that anxiety and a catastrophizing personality and anxiety pre-op increases your post-op pain, acute pain.
Isn't that amazing?
And also nausea and vomiting, which isn't as, we've got better drugs now for that, but even so, people still do have nausea and vomiting, and if you don't need a drug, I think it's better. Then the other interesting thing is there have been studies, I haven't looked at them recently, but maybe 5-6 years ago, that showed that acute pain post-op, so high acute pain post-op, increases your incidence of chronic post-surgical pain.
Oh, wow.
Right? So it's important to get on top of that pain in those first week, 2 weeks, in my opinion.
Yeah.
Because all I know is if I can help people in that immediate time, then hopefully I'm avoiding the chronic pain that can happen after surgery.
But I remember when I first came to you, I mean, you had people, you know, the whole surgery was full of people waiting to see you for pre-operative treatment, and I was like, wow, what is this? It's amazing. You know, so what is the length of time that you would see someone even post-operatively? So we know you do it pre-operative too.
If I can, and that's what I aim to do, but often I don't get to see the patient pre-op.
Right.
So I am then picking up the pieces afterwards post-op.
Right.
And that's why I think it takes longer for me to get a result, I'm sure.
Yeah.
I mean, I know, in fact, one of the sisters at the hospital yesterday said, oh, Euahna, thank goodness you've come today. There's such a difference when you treat the patients. And they've seen it.
Yeah.
But I don't work at all hospitals.
Yeah, of
it's only me.
Yeah, I know. And that's why you're so busy.
So if I see patients pre-op, I think it's easier to have a quicker result.
Mm-hmm.
But I usually suggest to patients that 1 or 2 treatments post-op in my rooms is beneficial for them generally.
Right.
I see them pre-op in the hospital if I can, if they're in hospital that long, you know.
Yep.
If one day I often don't get there, but, you know, for example, total knee replacements, I'll see pre-op if I can, day 1 or 2, and then day 4 before they go home.
Right.
Hips, maybe just once post-op. So the importance of seeing patients pre-op and the number of times I have to see them depends on the patient's symptoms, nerve, whether there is an added nerve issue going on, which means that I have to do a slightly different treatment prior to surgery.
Okay.
And that might take 1 or 2 treatments prior to the one just before.
Right.
And that's why the sooner I see people, the better. Because if I see a patient, you know, they've booked in to have a total knee replacement, hip replacement, whatever, 4 weeks, I say, make a time, let me see you, and then I can plan.
Yeah.
Do a treatment.
Yeah.
See you just within a few days or a day before your operation, if possible.
Yeah.
Even if you're not with a surgeon I work with, I can still do that.
Okay.
If your GP has referred you.
Yeah.
But then it limits, if it's not a surgeon I work with, then I have to wait until you are at home and you can come in to see me post-op.
Right.
So it varies.
Right.
And time varies according to site, history, chronicity, nerve pain that might be involved as well.
Is age a factor, do you think?
Age is not directly. It does alter how I treat patients, though.
In what way?
In that I can't push a fluid reduction. I can't push too much if someone's elderly because of the cardiac system. I have to think of that as an anaesthetist too, you know.
Right, yeah.
I can't sort of give a very strong lymphatic treatment the first time I see someone if they're elderly or if they've got a cardiac issue, if they've got a respiratory issue. So that's why it's a consultation of the patient prior to then deciding my plan of how I can help them and the limitations initially and why it might take a bit longer.
Yeah. I love that because what you're saying, what I'm hearing you say is there's no one size fits all.
One size does not fit all. And the real problem is everyone wants a recipe.
No, you know, you can't. I mean, I always say, you know, I was doing an infomercial for my coaching and mentorship sessions, and I was saying that each individual is as unique as a fingerprint. And you cannot say that what will work for Euahna will work for Therese. You know, we have different sensitivities, we have different vulnerabilities, we have different goals, we have different ways of seeing the world. And so I would imagine that you would do the same thing.
And anaesthetists, we are probably the specialty that is more aware of that than anyone because we deal with how people respond to our drugs every day.
Yeah.
As we give a drug, you expect someone to need a whole ampule and then they go to sleep on 1 ml rather than 5 mils.
Right.
And you go, wow.
And you're talking about general anaesthetics here.
No sedation.
Just
anything.
twilight sedation.
Anything.
Wow.
Anything.
Okay. Yeah,
as soon as you introduce anything into a patient, it's going to be an effect.
Of course. Yeah.
And so that's what I say with this. When people say, "Oh, how does this work?" Well, we didn't get onto that. There are photon receptors on cells, but if I'm giving a certain turned it off. Sorry.
Yeah.
If I give a certain amount of energy,
you can see it. Yeah.
Into you, something must happen.
Of course. Yeah.
I had an engineer yesterday that I was treating, and I said, "Well, what's happened? I've given you some photon energy there." And he said, and I said, "What happens to energy? Can it be destroyed?"
Never.
No, something will happen.
Exactly.
So then I've instigated. And another interesting thing, so that it's not wacky, is that of all the light that can go, so red light can transfer. I forgot to bring, but blue light or green light will not go past my skin.
Right.
It does not go through. So there's a window of light wavelength colours that will go through your skin. It's from 600 to 1,000 frequent nanometers. Anyway, the frequency. But of that, there are only certain little fragments of wavelengths that have a physiological effect in our body.
That's amazing.
And that's because that's the photon receptors. So we know there's a receptor that likes this one, which is 638 nanometers.
But it's the red light.
But only that red light is the best.
Right.
The other one can work, but 638 to about 658.
So the frequency of the light.
The frequency of the wavelength is important.
Right.
And then near infrared, it's about 810 or 850.
Okay.
Okay, 830, 810, 850. And then near infrared, 904.
Right.
Well, near infrared is 810 too.
And isn't it interesting that you say only red light works? Because when you look at the body in terms of the body is made up of energy, basically, and cells, obviously, which is what you've just explained. But the one energy that activates action is red.
Well, that's because I can get the red light to you, to your cells.
Fascinating.
See, I can't get there might be blue cell receptors, but I can't get the blue light to you.
Right. But it's still the red light.
Well, the red light, and it's not just the red light, it's those frequencies.
Yes.
And just understand there are frequencies. And in my opinion, there will be a huge number of other wavelengths that we'll be able to help people with down the track.
Yeah.
When we have more advancement in this area.
Yeah.
To actually show that there are other receptors, and we are finding new receptors all the time. The receptor that I think I mentioned to you first up, that's been most widely investigated, is on the mitochondria.
Yeah.
And that is the powerhouse of the cell. So it means that and it's the easiest one for me to describe to patients, but we know that there are ones on trip factors, a lot of other things. Anyway, we know opsins. So there are other receptors we're finding, and as I said, this is going to expand.
Oh, absolutely. It's already expanding. Yeah, absolutely.
And it will just be a matter of time, and then there will be receptors for blue light on our cells and things somewhere, because we started as I think we started as single cells in the development. And that, do you remember the amoeba?
Amoeba, yeah.
And so I remember when I was I can picture this and I wrote it on my, my science teacher, the sun, the little rock with a little bit of water, this little single cell, the sun coming down, right?
Yes.
Now that is life.
I know.
So the sun, the rays, the photons were utilized for that cell to live. So it does not seem odd.
No. It's, why it's odd to people, because I think people, when we look at each other in terms of mass. The body is a mass, rather than understanding that behind that mass, the body is like a portal to the energy that's behind it, and that energy is cells, right?
Cells. Lots of cells.
Yeah.
Lots of cells with their own little function, and that's why one of the most highly recognized experts in photobiomodulation is Professor Michael Hamblin. He used to be at Harvard, and he actually said, "Well, we all feel better when we lie in the sun," and we do, and so that you're absorbing some.
Absolutely.
It's just that now, with laser, with the red laser, which, by the way, Einstein predicted.
Yes.
Einstein predicted we would have a laser.
Yeah.
And actually Einstein received his Nobel Prize for the photoelectric effect, which was describing, not for his for the photoelectric effect, which is the idea that it's a particle.
Yeah.
Right?
Yeah.
So it's not surprising when you think about that if I give some light or photon energy into you, something must happen.
Absolutely, yeah.
And so even when I do an acupuncture point, which is with this, I'm already introducing some photons into your system. And photons then flow around in the blood,
right?
And they can be utilized where they're needed. So it's but for me, with respect to the pre and post-op, I just see it as being an adjunct to help patients
It's an add-on. It's definitely an add-on.
And it will be like a prescription. Maybe not in the way I'm going, not in my lifetime, I have to tell you.
No, I actually think it will be, Euahna.
That you would, well, in fact, the surgeon I'm working with can see it. He says, and I said, it'll be a prescription, just like we prescribe, doctors prescribe drugs for you post-op.
Yeah.
Well, there'll be the doctor will be saying, look, LED treatment. There'll be a photo biomodulation nurse or technician who will be in the ward, and they'll be going, yes, and I'll be saying, prescribe the treatment for this patient. They're not all the same.
No.
Everyone's different doses, different times, different amount, right?
Yep.
Different areas to be treated, depending on the age, lots of things. But and also there'll be the acupuncture, laser acupuncture treatment. And just for people who are thinking, I'm not quite sure about all this, the Royal Children's Hospital here in Melbourne. Have I mentioned the oral mucositis to you?
We discussed it the other day on the phone.
Yeah, but I haven't mentioned it. No. But I think it is an important thing to know that the Royal Children's Hospital use the machine that I use in my rooms, one of them, but the main machine I use in my rooms to treat children with what we call oral mucositis, which is when
ulcers in the mouth.
Ulcers in the mouth when children and adults get it. So Peter Mac have not quite got into it yet, but they're thinking about it. But the children's use the LED as a treatment to help these the children who have had bone marrow transplants, strong chemotherapy. And what happens when you have chemotherapy and immunosuppressants is that no tissue regenerates. Yes, you're getting rid of the cancer, but nothing does. And our tongue and we always are regenerating.
Yes.
That's why they get these severe ulcers in the whole mouth.
Oh, wow.
It's painful. They have to stay in hospital to actually have parental feeding, an IV feed. Yes. So the children's have been using it for over 10 years now.
That's amazing.
And it is standard protocol in England, in the UK, using light therapy.
Right.
But more importantly, when we've tried to do a double, what we call a double-blind trial, a random evidence-based medicine, which people might have heard about, and you do a pilot study first, and twice at the children's now we've done little pilot studies to say, well, now we'd like to do the big study, but it has to go through the ethics committee.
Yeah.
And the ethics committee have said that the pilot study showed such efficacy, meaning it was so positive. That we're not going to let any child be in the placebo arm and not get it.
Oh, that's amazing.
So that means they're using it.
Of course.
But there's no double-blind trial yet.
It's going to take a minute.
Well, you'll never get it at the children's because ethically they're not going to allow it.
On children.
And that will be the problem.
Yeah.
But as I said, there have been studies in the UK, so they've got the evidence there.
I really think that we're moving slowly in Australia because we know that Australia is a very conservative country and very science-based, very reluctant to trial something new. But look, 4 years ago, prior to COVID, you wouldn't be hearing about every second person is suffering depression and having a mental breakdown. So I think we're moving in the direction of adjunct treatments. We are moving in the direction of we're not just a physical body. There is something behind that physical body that we have to attend to. And these alternative remedies, therapies or adjunct, as you call it, are really part and parcel of how we look at a human being. And the prevention, in my mind, is always going to be better than the cure. It's always easier to prevent something than to come in and fix it after it's been damaged.
That's what I'm saying.
Exactly.
That's why pre-op treatment is the absolute, and that's what Rod Dalziel, when I worked with him, said, Euahna, you're treating them pre-op. It's made a huge difference. You're right. Because I said, I think I need to see them before. And when I started doing that, he said the difference is...
I've had your treatment. I know it works.
But I'm saying prior to surgery, it's a very obvious thing there.
Yeah, definitely. That's amazing. Your treatment is phenomenal, but we're going to come back in just a moment. We're going to take a quick break. Please come back and join me with our resident doctor, Dr. Euahna Varigos. where we talk some more about pain management. Don't go anywhere.